so you guys can familiarize yourselves. Alright, that should be enough time. Alright. So, just so you guys know, doing a couple pictures along the way. A couple pictures and take them and hope you enjoy them as well. Alright, so this gentleman had a seizure. So how we're going to break this down. We got the differential. The way I see it, we've got 4 big categories to think about. We've got things going on in the brain, primary CNS lesions. These things cause hyperactivity within the brain. It's either a mental effect, something like a neoplasm, AVN, or something like an underlying seizure disorder, or maybe a trauma, some sort of scar. Then we've got infections, things that can also increase that hyperactivity within the brain. And then we've got this last category, a couple other ones that kind of sneak up on you sometimes. Metabolic, endocrine, we've got to think about sugar, sodium, and calcium, and a couple of endocrine hormone disorders. Then finally we've got the toxins and alcohol and things with withdrawal. And we'll move into those in just a bit. So, this is a primary CNS issue. Let's think through some of this. We got a young patient. No prior history of seizure, no history of any stroke, no signs of any increased ICP, so no headache in this gentleman, no nausea, no vomiting, nothing to make us think that there's something going on inside. No altered mental status, and yet we do not have CT head. So you ask yourself, does this gentleman have any trauma? Nothing on exam, nothing per history, so probably not. Does this gentleman have any focal neurological deficits, or is he moving just fine? Well, it seems like he would move fine. So I think this is probably clear. So most likely this gentleman does not have any space occupying lesion. So let's move on now to infections. So there are a couple things about this person, this patient. Comes in, makes you think maybe he's got some sort of infection. Things we can think about would be something like a viral encephalitis, bacterial meningitis, maybe some sort of mass, infected mass, like an intracranial abscess. And then some of our zebras you might think about as well, malaria, toxo, neurocysticercosis. So let's talk about them. Now I want to know, does any of this fit? Now sure, this guy's got the recent travel, he's got his borderline temp, leukocytosis, even those really big findings that deteriorate higher. But then ask yourself, he doesn't really have much of that fever, chills, malaise. He's got no headache or neck stiffness to make you think of meningitis. No increased ICP symptoms, probably not that abscess. No altered mental status, probably not encephalitis. And no other signs, nothing really going with malaria. No anemia, no jaundice, no high fever. And there's not really a malaria in Jamaica. And none of this else really explains some of these other findings that we saw, the anxiety, tremulousness, EKG changes. So it could be infection, perhaps, but probably. So let's move on to metabolic and endocrine. So we know the sugar is normal, sodium is normal, calcium is normal, so probably not. Good news. In terms of endocrinology, we want to think about hormones now. So when we look at these symptoms, we think to ourselves, this could be something like an increase in sympathetic activity, which could go along with thyroid storm. However, we notice that this patient, unlike our patient here on the slide, does not have any stare or lid lag, does not have any skin or GI findings, and there's no evidence of any goiter. And yet we do not know the TSH or the T4. And so could it be? Maybe. We'll look at it up just now. And finally, we've got toxins and withdrawals, the drug category, my favorite. So now we know our patient endorses smoking marijuana, but denies everything else. And yet, we all also know from working here in county that everybody likes.
Yes, especially you.
So let's look again. So we have that constellation of symptoms we got here. And now if we think about it again, it all kind of goes along with this increase in sympathetic activity. The tachycardia, tachypnea, the hypothermia, as well as the neurologic symptoms, the anxiety, the tremor, the seizure, and maybe some rhabdo, what we saw with that hyperkalemia before. So how do we split this up? Increase in sympathetic activity, or increased activation, could either come from acute toxicity, or something like an upper, something like a cannabinoid, like a P2, crack cocaine, or tricyclic antidepressants, maybe an overdose. Or it could come from withdrawal of a depressant, like an alcohol, benzo, or opioid. So let's break it down. So now if you look over here, you see this little old lady. I bet she could tell you what happens when you have acute withdrawal of alcohol. So it's actually pretty similar to our patient's symptoms if you think about it. You got the autonomic instability, it can give you the tachycardia, tachypnea, the hyperthermia. The withdrawal, the increase in sympathetic or neurologic activity can give you the anxiety, it can give you the tremor, the seizure as well. And if you also notice our AST-ALT ratio was a 2-to-1, which could go along with alcohol as well. And there was a negative ETOH, which could be from absence of alcohol. But it doesn't really explain the EKG findings or that weird CT abdomen that we saw before. How about opioid withdrawal? I know we've all been there. So maybe anxiety, sure, can give you some abdominal discomfort. It's possible. Although those foreign bodies, not exactly sure how that would fit in here, but it still could be potentially something we'll touch on in just a moment. Maybe some tachycardia. So sometimes with opioid withdrawal, you get tachycardia, tachypnea. But yet overall, it's uncommon and so much less likely in this setting. However, the things that we do tend to see are the nausea, the vomiting, the diarrhea, the diaphoresis, myalgias, and malaise. These are the things we most commonly see, and the fact that this patient has none of those makes it much less likely. And actually, although seizures can be a side effect of opioid withdrawal in infants and children, much less likely in adults. So what about the TCA toxicity? Sure, you can get the tachycardia, the anxiety, the tremor, the seizure. You can even get some QTC prolongation, which our patient had a mild, like a borderline QTC prolong. But the thing that you really look for in this AVR, in these patients, is R prime wave in the AVR. And our patient did not have this, which basically precludes this patient from having TCA toxicity on board. And furthermore, this patient also has no altered mental status, which is a very common finding when you see these patients come in with TCA toxicity. Now, what about the synthetic cannabinoids? You got your K2, Spice, your Bombay Blue. Yeah, they can give you all this. And actually, these guys can take you for quite a ride. It could be tachycardia, anxiety, tremor, seizure, even lactic acidosis. And we know our patient takes marijuana. You know, he knows it's taking it. So it's not that big of a step to jump over to K2. But in this case, I do not think that puffing the magic dragon is going to give you these EKG changes. And it's definitely not going to give you that weird stuff in the CT abdomen. Now, crack cocaine. That's a hell of a drug. That could certainly give you all the symptoms that we see here. And we actually did have a positive cocaine-only detox. Now, QTC prolongation on those patients with EKG with borderline, it's actually a fairly common thing to see in cocaine use because that's sodium channel blockade. It can also give you that rhabdo, which this patient may have had some borderline evidence of. But about that abdominal discomfort in those foreign bodies, again, it doesn't quite match up. So let's go on. Let's touch back on that in a minute. So what do we narrow it down to? We're thinking maybe tox, either acute toxicity withdrawal, cocaine, or synthetic cannabinoids, possibly ETOH, benzo withdrawal, or maybe still that hypothyroidism we're talking about. But what about CT? How does this fit in? So let's take another quick look. When you guys look at this, what are you thinking?
Drug needle.
I know what I'm thinking. I think this guy went to town. Maybe got a little too frisky with the balloon party. But actually, it may not be so far from the truth. So, we never really saw anything like this back in Arkansas called body stuffers. So I had to ask myself, is this a sad case of a poor young man roped into a life of crime? But this guy doesn't know how to party. I think it's probably the first one. Most likely, when we put it all together, we've got this acute cocaine toxicity, most likely from unintentional absorption of ingested cocaine packets, and coming in a patient comes in as a body stuffer.